Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, and welcome to the Baylor College of Medicine Lung Institute. My name is Shanda Blackmon, and I'm the Executive Director of the Lung Institute. And today we're joined by Dr. Shawn Groth, the Chief of our Thoracic Surgery Division, the David Sugarbaker Endowed Chair of Thoracic Surgery. And we're so excited to have you here, Shawn. He's trained at the Brigham with Dr. Sugarbaker and now has been under Dr. Sugarbaker, and now he's running the program that Dr. Sugarbaker built. Welcome.
Well, thanks for having me, Dr. Blackmon. It's really a pleasure.
Yeah, so today we're going to talk a little bit about a procedure called tracheobronchoplasty. Tell me a little bit about what that is.
Well, tracheobronchoplasty is a way to provide permanent stabilization of an airway that collapses abnormally.
And what kind of patients get tracheobronchoplasty? Is it somebody who has a chronic cough? Is it someone who's got a weakened immune system? Or what kinds of patients are at risk?
It's for a patient with excessive central airway collapse. Now, there are two ends of that spectrum. One is excessive or hyperdynamic airway collapse. Other end of the spectrum is tracheobronchomalacia.
Okay, and in those patients, I think the common thread is that the back part of the airway that's usually made of just a membranous airway, it's not covered by cartilage, as opposed to the front, which is an arch of cartilage arching over. That back part is almost stretched out, thinned out, doesn't hold its own form, and bellows up into the airway. Is that a reasonable way to describe it?
For excessive dynamic airway collapse, yes. But now we all have a little bit of physiologic collapse when we forcefully breathe. And there's some threshold at which that's abnormal. That threshold is moved, depending on the literature, but on the order of 50 to 70 or 90%. On the other end of the spectrum, though, is tracheobronchomalacia, which is a problem of the cartilage on the firm part of the airway, either anteriorly or laterally, both of which cause different morphologies of tracheobronchomalacia.
And it's a little bit too bendy and collapses and flattens the trachea. So instead of getting this nice Roman arch form, you get sort of like a tent that's prop. When we go camping, my kids make fun of the tent. When I try to put it up, it just sort of falls down.
That's a crescent-shaped morphology, so that's when the anterior, the front wall of the trachea has lost its cartilage integrity. There's also other forms, more of a saber-tooth deformity, where the lateral part doesn't work well and has a different morphology.
Okay.
And there can even be circumferential when there's just circumferential damage to the airway.
Okay. And then in those cases, you have a patient. What kind of patient, does the patient just know that they have it, or what are the symptoms that people have?
It's not very well appreciated, probably underdiagnosed. Most patients have shortness of breath. Some patients notice cough. Maybe that's brought in with spasms of coughing by simple things like talking and breathing. But typically, there's a fair amount of patients out there with this disorder that just aren't being referred.
And when people are presenting with a chronic cough, maybe, is it like a barky cough? I've noticed that sometimes they have a distinct cough.
It can be, yes, almost like a croup type of cough.
Like a croupish cough, and it's chronic, it doesn't go away, they don't have signs or symptoms of an infection, and it just keeps on going. If they have like a primary care provider that doesn't really seem to appreciate that they might have a true problem, do you recommend that they go to a pulmonary doctor before they come to you, or do you evaluate people directly for this?
We do both ways, either through a pulmonary doctor or directly to us.
And then how do you diagnose it?
Good question. It's not very well. The gold standard is a bronchoscopy with the patient comfortable, but awake enough to participate and do some dynamic maneuvers where we can actually watch the airway collapse. Of course, we're looking for non-invasive ways too, and there are dynamic or chest CT scans that are obtained with patients breathing in and breathing out and looking again for collapse of the airways.
So you get a CAT scan, sort of like low-dose CAT scan for lung cancer screening, or a typical CAT scan that you might get if you go into the emergency room and they're worried about something. And during the CAT scan, you have them take a deep breath and breathe a lot of air into the lungs, and you do a quick scan, and then you have them breathe all the air out, and you do another scan, and you're kind of measuring that difference?
Correct. Different than a normal CAT scan where they just breathe in and hold it. This is where they breathe in all the way and then also breathe out. So they have several different images at the various portions of the breathing phase.
So you'd said that we all have some collapse of our airway to some degree.
Yeah.
What's the threshold? At what point do you say this person just has that normal collapse of their airway versus this person has severe collapse, they need a tracheobronchoplasty?
It's a good question. Now, classically, that threshold is 50%. The problem is that upwards of nearly 80% of normal people or asymptomatic people who undergo a dynamic chest CT scan have that degree of collapse.
Oh, wow.
So there's a lack of specificity. A lot of investigators, especially surgeons, have moved that threshold upwards to maybe 70%, and then considering more than 90% as being severe. In that severe category is what we're looking for surgery.
Okay, so you're looking for somebody whose airway, not side to side, but front to back, collapses 90% of when it's fully open, goes down
Correct.
and closes almost 90%.
Almost at least 90%.
And that's pretty severe.
That's
I
pretty
can imagine
bad.
it's pretty hard to breathe when your airways collapse 90%.
Absolutely.
Okay. And then once you figure out this patient's airway is really collapsing, whatever the cause,
Yeah.
and it's worrisome, and they've got terrible symptoms, what do you tell them then?
Well, I think we have to start with medical management. So for patients who have severe tracheobronchomalacia who are considering airway stabilization, we want to optimize their medical condition. So working on obesity, working on gastroesophageal reflux, both of which can make this worse, and then working on treating the small airway disease, which involves things like bronchodilators and things to help patients clear secretions.
So we talked about this a little bit on some of our other sessions, how important it is for patients to understand clearing their secretions. And sometimes that's hypertonic saline, sometimes that's aerosolized medication, sometimes that's a vest that sort of shakes things up and helps people get things loose, or what we call a flutter valve that helps to create vibrations in the airway to help people cough things out. So they go through the medical therapy, they sort of max out with medical therapy.
Sure.
Then what?
So our evaluations include two main things. One is an awake bronchoscopy.
Okay.
Another one is a dynamic CT scan.
Okay.
There are temporizing things we can do, like BiPAP, CPAP, which provide some relief. And then we can think about for potential candidates, two methods of long-term or temporary airway stabilization, either with a stent or with surgery, a tracheobronchoplasty.
And what kind of stents do you use? Do you use metal stents? Do you covered stents, uncovered? The stents that go down both airways, or just a tubular stent?
It depends on the pathology, oftentimes a Y silicone stent.
Okay. And the Y silicone stents are used because they're sort of inert, as you say, and they don't really create as much inflammation as, say, a metal one, which can actually create more scar tissue and
Sure.
cause strictures, right?
Right.
So if you put these silicone Y stents in, does it make it harder for people to cough secretions out?
Yes. So these are oftentimes used in some centers as a way to decide whether a patient might get better by long-term stabilization by surgery. The problem is that complications with stents are common. About 80% of patients have some degree of problems, and most of that is hard time clearing secretions.
Yeah.
Infections, other problems. So it's hard to know that if they don't do well with the stent, if that's just because they're having trouble with the stent, or if it means they're not going to do well with surgery.
But if they do great with the stent, and the stent's making it hard for them to cough junk out,
Yeah.
but yet they've got this stent in and they
Yeah.
feel much better, that kind of gives you some confidence to know that, number one, you might have the right diagnosis. Number two, that if you can stabilize the airway, they are much more likely to get better.
True.
Okay. So you put the Y stent in, they get better. How long do you leave the Y stent in?
Usually 2 weeks at the most.
Okay. So they get the Y stent out, and then how do you prepare patients for this surgery?
Again, optimizing all the medical conditions. We oftentimes will get pulmonary function tests too.
Okay.
Now, those aren't great for selecting patients for the procedure. Some degree of patients will have restrictive or obstructive processes seen on PFTs, and probably about 20% will have actually normal PFTs. And they oftentimes, 34% of the time, get worse after surgery. So they're really helping us decide about the risk of having perioperative problems, but they're routine part of the evaluation. And again, a bronchoscopy and dynamic chest CT.
Now, how do you decide how you're going to fix the airway? Can you tell me a little bit about your approach, your choice of approach, and then technically how you do it? When
Sure.
I was a resident 20 years ago, this was a horrible surgery to go through. We used to cut the latissimus muscle, which is the muscle on the side of the chest, the serratus muscle, which is another muscle on the side of the chest, and then spread the ribs, put a big retractor in that cranks open the ribs, and then have the whole airway displayed. And it was a big surgery. And patients sometimes would regret that they had the surgery because they had so much pain after that. And it put them at risk for what we call sort of neuropathic, chronic, post-thoracotomy pain syndrome.
Sure.
How is what you do different from that?
You're right. So the traditional way is a large thoracotomy to expose a trachea and do the stabilization procedure, a tracheobronchoplasty. You're right. A lot of these patients have COPD, and it can be very morbid for them. And so in recent years, we've adopted a robotic approach, so much less invasive, easier recovery for patients, and likely less complications.
And what does the robot provide for you that other techniques don't?
So compared to an open technique, there's obviously less pain. I think we actually have better exposure because once we're there, we have very great visualization, very dexterous instruments to do the job.
Okay.
People have tried VATS, traditional VATS approaches in the past, and you can imagine with unflexible instruments, it can be very challenging to do that operation, and that hasn't really gained a lot of penetrance. But with robotics, the instruments are so flexible, it's very straightforward to do.
And you're probably one of the most talented robotic surgeons in the United States. I love just going and peeking through the window and watching you do cases. So when you go in and you're doing this type of surgery with the robot, you're actually tying the knots with the robot, right?
That's
And you're
correct.
placing the mesh and cutting the mesh in the chest.
Correct.
So tell me a little bit about what you do. Like, what's this surgery all about? Why does it work, and what are you putting in?
Right. So first, we expose the trachea in the upper parts of the bronchi, the main airways of the right and left lung,
And
separating
that's through the right chest
through the right
always.
chest.
Yeah.
That's correct. Dividing the azygous vein, taking lymph nodes out of the way, separating the esophagus off the back wall of the trachea.
Okay.
Then we sew a piece of mesh, polypropylene mesh, to plicate, to imbricate, to bring the back wall closer in proximity, so it provides a little bit more normal morphology of the airway.
So that's a little bit like when I have a little kid and they're wearing a little outfit, that we smock it, where you pleat it a little bit to tighten it up and give it some texture. So you're basically pleating and putting the back wall of the airway to make it tighter and shorter and make that bow of an arch of the airway more pronounced.
Correct. Rather than allowing the airway to collapse, as you said, in that crescent-shaped deformity, it provides more of that D-shaped configuration.
Okay. And are there any complications that are known from this surgery or anything that we should warn patients about?
Outside of post-thoracoscopy pain, which is typically fairly short-lived, risk of pneumonia, risk of infection, kind of general risks of anesthesia in
And
surgery.
then the mesh can sometimes erode, but it doesn't normally do that when you're really careful about how you're placing those sutures.
Correct. That's pretty unusual, especially if the sutures aren't full thickness.
Okay. And then how long does it take patients to recover from this?
Usually in the hospital, 3 to 5 days.
Okay.
And every patient's a little bit different in the recovery pathway, but several weeks.
Okay. And what % of patients do you think benefit from the surgery?
In terms of just basic symptom improvement of shortness of breath, respiratory quality of life scores upwards of about 80%.
That's amazing.
Yeah.
There aren't that many procedures that we do that make people 80% of the time make them feel that much better. So that's a win. And what kinds of patients come to you? Are they only local Houston patients? You're pretty renowned in surgery. Do people come from all over the United States and even outside the United States?
They do, really, from the Houston market all the way from around the U.S. and around the world.
Okay. And At the Lung Institute, we really emphasize the importance of multidisciplinary care. Do you work with
Absolutely.
certain individuals that sort of help you usher these patients correctly along the right path?
Absolutely, all the time, including our interventional pulmonologists like Javeria Safi, otolaryngologists, general pulmonary medicine doctors. It's all a very much a team effort.
So when you're talking about doing these cases, do you ever have to revise them? Do you ever have patients that have been sent to you from a complication from these
Sure.
procedures that you have to treat?
I have not. It's been described, but I've not had that experience so far.
Yeah, I've taken care of one patient that had the mesh erode, and we basically just took the whole mesh out and then had to patch little areas in the airway. But from what I could tell from going through the literature, it's extremely rare for that to happen.
Absolutely.
Because it's usually not a lot of other disease in that area and it's isolated. Okay, so let's look a little bit on the side. If you have a patient that you had a tracheostomy or you had some damage to your airway and you've got a narrowing, do you also cut that part of the airway out and put it back together?
Yes, that's often part of the same.
But that's different from tracheobronchoplasty. That's where you're actually taking out the diseased part of the airway, repairing it primarily by putting the two ends back together, as opposed to patching the back to create a better open airway.
Correct. So with a tracheal resection, such as trauma after a trach or intubation, we're taking out the diseased part, putting the good stuff back together, versus a tracheobronchoplasty, we don't resect anything, but we just stabilize the airway to give it better configuration with mesh on the backside.
And you do both of those, correct?
We do both of those, yep.
Yeah, good. Well, this is just an amazing opportunity to hear about what you're doing. Make sure everyone around us is aware of this surgery that I think is underutilized. I mean, I
Absolutely.
think when you look at the benefit and the likelihood of having an improved quality of life and the underdiagnosis, we really need to work to get the word out so that patients are aware that this is an option if they do have this disease called tracheomalacia. I think it's really important.
Absolutely. Maybe 20 to 50% of patients with COPD have this, and we certainly don't see that number in our practice.
Wow. Okay. Well, thank you for joining us.
You bet. Thank you. Thanks for having me.
And thanks for joining us at the Baylor College of Medicine Lung Institute on-air podcast for tracheobronchomalacia treatment with tracheobronchoplasty, robotic approach from Dr. Shawn Groth. Thank you.